Good evening. This is Dr. Ben Weitz, and thank you for joining the Functional Medicine Discussion Group meeting. And tonight we'll be speaking with Dr. Ali Rezaie, and he'll be giving us an update on some of the latest research on small intestinal bacterial overgrowth, which is believed to be the main cause of irritable bowel syndrome, which is the most common gastrointestinal condition. Thank you for joining the Functional Medicine Discussion Group this evening. And I want to thank our sponsor for this evening, Integrative Therapeutics. So Integrative Therapeutics is one of the few professional brands of supplements that we use in our office, and they have several excellent products that can be beneficial for SIBO. The first product I'd like to highlight is the Physician's Elemental Diet. And the Physician's Elemental Diet is a great way to starve the bacteria involved in SIBO. So we have several different strategies for getting rid of SIBO. One of them is to kill the bacteria with antimicrobials or antibiotics. Another strategy is to starve the bacteria. And the Physician's Elemental Diet is food, essentially, that's in the most elemental broken down form, so your digestive system essentially can rest. It doesn't really have to work to digest any of the food. And another product I'd like to mention is a product that they have, which is called Motility Activator, which is my favorite natural prokinetic. And I'm sure Dr. Rezaie will mention the fact that a big part of SIBO is decreased intestinal motility. So to reset the migrating motor complex in a natural way, Motility Activator is a great way to do that. One more product I'd like to mention that you might not think of that can be very beneficial for SIBO is theracumin. So theracumin is their highly absorbable form of curcumin. And one of the things that happens with SIBO, and I don't know if this is something that Dr. Rezaie will mention, but some of the data indicates that you get a gut hypersensitivity, and that hypersensitivity increases the symptoms, and curcumin is an excellent way to downgrade that gut hypersensitivity. So now I'd like to introduce Dr. Ali Rezaie, who is a world-renowned gastroenterologist and researcher with a focus on IBS and the gut microbiome. He's the medical director of the GI Motility Lab at Cedars-Sinai Hospital. Dr. Rezaie has published over 100 scientific articles in peer-reviewed journals, and his works have been cited more than 6,000 times by other scientific journals. He's also the associate editor of the Journal of Digestive Disease and Sciences. And Dr. Rezaie is the co-author, along with Dr. Pimentel, of the new book, The Microbiome Connection, Your Guide to IBS, SIBO, and Low-Fermentation Diet. Dr. Rezaie, you have the floor.
Okay. Do you see what I'm presenting?
Yes.
Here you go. Perfect.
Good.
So I'm gonna give a talk, and I'm gonna leave some time for questions and answer at the end. So we have, because there's a lot of things about SIBO that you can't just fit into a talk. So I'm gonna talk about SIBO. I'm gonna talk about EMO and how to diagnose and treat both, essentially. So for small intestinal bacterial overgrowth, one important thing is that what is the actual definition? For the longest time, the definition was 10 to the 5, meaning that more than 100,000 bacteria in the small bowel. But that was based on the data from the blind loop diseases. Before we had PPIs and we couldn't control peptic ulcer disease, the only way to control a refractory ulcer was surgery. And one of the surgeries that we used to do was Billroth 2. Essentially, you take, similar to gastric bypass, you take the stomach out of the luminal continuance, and that obviously left the bowel to have a blind loop. And bacteria overgrew in that area, and that's what we called it blind loop syndrome at that time. And this is from 50s and 60s. At that time, the cutoff that was chosen was 10 to the 5, mostly because we used 10 to the 5 for UTI too. So they just said, okay, let's use the same thing. But after multiple healthy controlled studies were done, it's clear that having 1,000 or more bacteria per ml in the small bowel, granted that the aspiration is not contaminated, is the abnormal cutoff. So what has been now shown that we showed in the North American consensus and also in the SIBO guidelines, that the cutoff is 10 to the 3 or 1,000. So another thing is that, okay, bacterial overgrowth is not an infection. It's essentially dislocation of colonic bacteria into the small bowel. And then talking about the intestinal methanogen overgrowth here as well, is that intestinal methanogen overgrowth can happen in the small bowel or the colon or both. So it's not necessarily a type of SIBO because it's not just small bowel related. So that's a disclosure. Another important thing here is that if you look at the colon here, we have about a trillion bacteria per ml with in the colon. And also when we look at the mouth, it's about a billion, about 10 to the 9 per ml. And it's fascinating that the small bowel has less than 1,000. And the way it keeps itself clean is through mainly housekeeper waves or migrating motor complex phase 3s, which are the sweeping waves that start from the beginning of the small bowel, sweep through the small bowel, and get all the way to the colon. And that cleans the small bowel from the excessive amount of bacteria. And they occur every 2 hours, and they last in each segment for about 5 to 8 minutes. Also, stomach acid is important, but more and more we're understanding is not as important as the housekeeper waves. And in fact, we do have patients with gastrectomy that as long as their small bowel is functioning well, they don't get SIBO. So the most important factor remains the housekeeper waves. Obviously, antibacterial effects of bile and pancreatic excretion is also a factor, and also the role of ileocecal valve as well. And again, we do see a lot of patients with Crohn's disease whose ileocecal valve is removed, but they do not get SIBO simply because their housekeeper waves are normal. Meaning that, again, when you have a normal housekeeper wave, you can essentially outpower the other defense mechanisms. We do intraduodenal manometry, and this is a high resolution one that we place it into the jejunum, and we look at these contractions that you see that the contractions happen about 11 times per minute, and they last about 5 to 8 minutes on each segment of the small bowel. So there are a lot of causes for a SIBO. So one of the, and it's important to remember, it's not a primary disease. It's a secondary disease that can happen in the setting of post-surgical disease that we talked about, the blind loop. And also adhesions very commonly can happen. Adhesions can happen in the setting of the virgin abdomen, meaning that somebody who hasn't had an abdominal surgery in the past. The most common cause of that is actually endometriosis. Medication, any medication that slows down the gut, such as narcotic and anticholinergic, can do this. Chronic pancreatitis, because the pancreatic enzymes are not being produced, is very commonly associated with bacterial overgrowth. And also small bowel diverticulum, fibrous bands, they are very commonly associated with SIBO. The most common cause, though, is essentially small bowel dysmotility. This can happen in the setting of connective tissue disease, diabetes, very commonly in the setting of post-infectious irritable bowel syndrome or post-infectious anti-vinculin antibodies. So the most common cause of this is Campylobacter, but it can happen in the setting of E. coli as well. What happens is that these antivinculin antibodies, they affect the motility of the gut by affecting the enteric nervous system, and then the migrative motor complexes become so infrequent or sometimes completely absent. So whenever there is inflammation in the small bowel, the same story. You can have a superimposed bacterial overgrowth. So how about the PPIs? So if you look at the literature, it's actually quite, it swings to a fact that PPIs don't change the small bowel microbiome. There's some positive studies, but the bigger studies are actually negative, which is interesting. And it's probably because of the fact that PPIs do not change the pH of the small bowel. The minute that the chyme, which is a mixture of the food with acid, enters the small bowel, that gets neutralized by pancreatic bicarbonate within 5 centimeters of the pylorus. And no matter what the pH of that chyme is, the pH of the duodenum remains constant at around 5.5 to 6. So probably that's one of the reasons. Having said that, yes, in somebody who has other comorbidities, immunosuppression, yes, PPI can cause trouble, but generally speaking, we are not seeing that type of abnormality. And I mean, if you look at the deep sequencing data, you can see that it's almost a perfect overlap between people who are on PPI and not on PPI. Even based on culture, it was not different. But nevertheless, I guess this what this points at is that as long as you have a healthy housekeeper wave, then you are good. And our focus mostly should be on restoration of the bacterial balance, and next restoration of migrative motor complexes to help these patients. So these are the symptoms. You're all familiar with the symptoms of bacterial overgrowth. Most common thing are abdominal distension and bloating, obviously postprandially. Generally, they're the best in the morning, and as the day goes along, they get worse. They have fatigue, they have postprandial brain fog, they can have weight loss, weight gain, they can have diarrhea and urgency, which is more common with hydrogen and hydrogen sulfide producing bacteria. Or they can happen to have constipation, which is mostly in the setting of EMO. However, these are not universal rules. You're going to see patients with EMO who have diarrhea. You're going to see patients with hydrogen SIBO who have constipation. So it's just that people with EMO have higher chance of getting constipation. That doesn't mean that every EMO patient is constipated. So this is a simplified pathway of gas production by microbiome. So the first step is as simple as you can put it, is that carbohydrate breaks down into carbon dioxide, hydrogen, and that hydrogen can be used by methanogens to produce methane. Bacteria can produce acetone out of it. They can produce hydrogen sulfide and even produce nitrates. Remember, our cells do not produce hydrogen or methane. So any hydrogen or methane found in our body is produced by gut microbiome. So this is essentially what I was saying. So patients with EMO have 3.5 times more likely chance of having constipation as compared to people who don't have EMO. What tells you there is that, well, not every EMO patient has constipation. Another important thing about methane is that the higher the methane, the more severe the bloating and abdominal distension. Another important thing is that Methane, unlike hydrogen, is an active gasotransmitter, meaning that by itself it has physiologic effects. So if you infuse methane into small bowel of dogs, it decreases the transit by 70%. So how do we diagnose it? So obviously the gold standard is small bowel aspiration. So right off the bat, this is not for diagnosis of EMO. We can't culture methanogens at this point, except for very specialized labs. So for diagnosis of EMO, we're only left with breath testing. This is for diagnosis of non-methanogenic bacteria in the small bowel. So what are the advantages? The advantages is that, well, antibiotic, you can do the antibiotic sensitivity on whatever you culture, and you do very directed therapy. Also, it diagnoses SIBO, which is commonly happen with small intestinal bacterial overgrowth. So in that scenario, you obviously treat the patient for both. The problem is that we have 20% chance of contamination rate, and that's the data coming from Mayo. But the problem is that this is done by the usual single lumen catheters that we do through the scope. So you put the scope down through the mouth into the esophagus, stomach, and then small bowel. While going through that, the suction channel of the scope gets contaminated by the oral mucosa, and also whatever stuff is in the stomach and the esophagus. So when you put a single lumen that the tip is not protected, some of that stuff goes into the catheter, and you culture that as if it was in the small bowel, and you aspirate it from there. So you get contamination rate. So if you use those rudimentary catheters, then you get a 20% contamination rate. Well, hopefully next year there will be protected catheters available. Not hopefully, there will be protected catheters available that will increase our sensitivity and specificity of small bowel aspiration. Another issue is the sampling error, right? So you're sampling like 5 centimeters of small bowel, and you're hoping that that kind of like represents the whole 20 feet of small bowel. Well, it won't. So there's a sampling error there. So there is that problem as well. And we can't culture all the bacteria, and also it's invasive and time consuming. Okay. So as you can see, it's even though it's called gold standard, it's almost silver because it has some deficiencies. So, and at the bottom is the catheter that I was talking about. And these are the catheters that we're using right now, but it's still only at the research level. So we don't have contamination rate at our center. So breath testing. So breath testing, essentially, it's when the food goes into the small bowel. If there's excessive bacteria in there, that gets fermented, the gas goes into the lungs, and then you breathe it out, right? With the same concept, you could give glucose and lactulose and just monitor the levels of hydrogen and methane. That happens every 15 minutes to see if there is excessive amount of bacteria in the small bowel. You also do measure CO2 just to, you are able to standardize each breath sample based on the alveolar level. So what are the pros here? Well, it's non-invasive. It can assess a longer segment of small bowel as compared to aspiration. It's hydrogen and methane are exclusive biomarkers of microbiome, and also it tailors antibiotic therapy, as we will talk in the next few slides, and also predicts response to antibiotic therapy, right? So these traits are not found in the small bowel aspiration. Okay, what are the cons? Well, I mean, if the bacteria that is causing trouble is non-fermenting, which is not common, but it does happen, then it can you can miss it, obviously. Sometimes if you have ultra fast transit, such as things go through your small bowel within 15 minutes in the setting of some neuroendocrine tumors. Obviously, the sugar gets to the colon quickly and you miss it. One important thing is that when the sugar gets to the colon, it takes 40 minutes. It takes 40 minutes for the bacteria that is exposed to that sugar in the colon to produce a hydrogen to a level that is 20 parts per million detected in the breath. So, so there is a lag in there. The reason why I'm saying this is that some use scintigraphy to criticize breath testing, saying that, well, by the time that 5% of the medium is in the colon, while 95% of the small bowel, now we're seeing a rise in the breath hydrogen. So this is coming from the secum from that 5%. So, but that's a little bit of a flawed theory because, well, first of all, 95% of that medium is still in the small bowel. Number two is that the bacteria in the colon takes 40 minutes to produce a hydrogen to be detected in the breath, and scintigraphy does not account for that lag. It's not an immediate phenomenon. So, and because of that, we use the 90-minute mark for the overgrowth. This is a healthy control sort of study that we did a while back on more than like 800 asymptomatic controls. So overall, the specificity is about 85%. But if it's done in centers that they know what they're doing, it's about 95%. These are centers, well, they're compliant with the patient's diet. They ask the questions whether they're compliant. They do the test correctly. They calibrate the machines correctly. So in that scenario, obviously, the quality of the test goes up and the specificity becomes about 95%. But there's no question that there is a group of healthy controls or a healthy, quote unquote, people with no GI symptoms and that their breath test is positive. Now, the question becomes is that, well, is this a false positive or a true patients with SIBO that is just asymptomatic? Because remember, asymptomatic dysbiosis does exist. A lot of people with H. pylori are walking around with virtually no symptom at all. And asymptomatic bacteriuria can happen all the time, especially during pregnancy. So it's not an uncommon thing. So this can happen. One study that essentially proved that is the study by Jessica Allegretti, that what they did is that they looked at people who received a fecal transplantation for a C. diff infection. So for people who C. diff was eradicated, but they develop IBS-like symptoms, if the donor was breath test positive, the chance of getting those symptoms was 50%, as opposed to if donor was breath test negative, which was 14%. So that means that those, even though those individuals had no symptoms, their breath test was positive, so there is something wrong with their microbiome. So giving that microbiome to patients with C. diff infection caused IBS, which is a fascinating concept. So if you want to do breath testing in your office or see what are the indications, preparation, and interpretation of breath testing is, you can use North American consensus as a guide for yourself. That now it's been 5 years since we published that. So this is how a normal breath test looks like. So patient fast overnight, they come in and we measure hydrogen or methane adjusted based on CO2. Every 30 minutes, every 15 minutes, we measure it. And usually what we see is that if you do it for 180 minutes, you see a rise at the end. Sometimes you see a rise a little bit earlier, but What is positive is if you have more than 20 parts per million of rise from baseline within 90 minutes, that means that there is excessive amount of bacteria in the small bowel that is fermenting and repeating that up. So just give you, it's interesting that that cutoff kind of correlates with deep sequencing data as well. So this is a small bowel aspiration data based on deep sequencing. And very commonly, proteobacteria are very abundant in patients with SIBO. That correlates with it. And firmicutes are actually low, so which is interesting. So in these patients we're seeing. And even correlated with energy metabolism of hydrogen production pathways of bacteria. So it seems like the 90 minutes is almost a perfect cutoff for lactulose breath testing. For the glucose breath testing, also we proposed a 90-minute cutoff. Having said that, because glucose gets absorbed within the first 2 or 3 feet of the small bowel, you can just look at the whole 120 minutes of data. One important thing about glucose is that, well, there's now debate, and then probably we're going to change things in the next North American consensus, that the cutoff probably for glucose should be lower because it doesn't cover the whole small bowel. And instead of 20, the data, especially the data that recently Bill Shea proposed, is that probably the best cutoff is 12. So for methane, though, it's the cutoff is well established. The cutoff is 10 parts per million. And this is, as I said, it can be the small bowel or the colon. So you don't look at the rise, you look at an absolute number, okay? And this 10 part per million, it's interesting that it works both for glucose and lactulose. And this is a paper we just published I think about 6 months ago, that it works both for glucose and lactulose, and also correlates with constipation, gas, and less diarrhea. More importantly, it correlates with the load of Methanobrevibacter smithii, which is the main archaea in our body that produces methane, okay? And also positivity remains stable on repeated measurements if you don't treat the patient. So that's very important. Because one argument is that, well, is methane is just a sign of a slow transit? Well, I mean, the answer is no, because sometimes we give antibiotics to somebody with emo and no laxative or anything, and methane drops, and the patient has less symptoms. So it's not just a matter of transit. And another very cool thing that we showed is that if you treat the patient for 14 days and you measure methane every day, fasting methane, it's actually very nicely, you see a drop in the methane levels with antibiotic therapy. This is very important because, for example, if I see a patient that now, after 7 days, responded to therapy, then next time that I treat patient, I will do it for 7 days. I won't do a 14-day course. On the other side, if I see that, okay, on the day 14, methane is still elevated, that means that I'm using the wrong antibiotic. So I will use a different antibiotic or whatever modality you want to use, the plant-based antibiotics, or you want to do elemental diet. So, but regardless, whatever you did, you need to switch gears. So how do we manage bacterial overgrowth? Essentially, we think of it as 3 pillars. Number one is that, is there a modifiable underlying cause that you can get rid of? For example, is there narcotics on board, and can you get rid of it? Or can you give antagonists to narcotics? Can you decrease the amount of inflammation in the small bowel? So, but unfortunately, not many times you will find a modifiable cause of SIBO. So you need to do induction of remission, which you can do antibiotic or elemental diet, or you can do maintenance of remission. That essentially includes diet, MMC, sort of modulating drugs that people talk about, and also counseling the patient regarding recurrence. So it's important to understand that if antibiotics have an efficacy of about 50%, so that's very important to understand, because just because one patient does not respond to antibiotic therapy, that doesn't mean that patient doesn't have SIBO. Most of the studies have looked into hydrogen SIBO, and the antibiotics that we have data on. I'm not going into the plant-based antibiotics because that's not the area of my expertise. You guys know more than me about that. But the antibiotics that we have by prescription, rifaximin, ciprofloxacin, neomycin, and Bactrim and Flagyl has been tested and showed positive response. Data for rifaximin is actually interesting because we know that rifaximin is approved for IBS diarrhea, but the only determinant of response that we could find that determines the degree of response in IBS patients to rifaximin is positivity of breath test. If breath test was negative, the response was 26%, which is less than placebo. And if it was positive, it was 56%. If the response was that the breath test became normal at the end of the treatment, the response rate was 76%. So it determines a response in IBS patients. So how about EMO? Well, methanogens are refractory to a lot of antibiotics. So what we need to do is to suppress the hydrogen-producing bacteria so they can't produce methane, and also suppress the archaea. So usually we do that, for example, with rifaximin or neomycin, or rifaximin or Flagyl. Augmentin we anecdotally use, so that's a treatment that we try. So Ben talked about the data on the elemental diet. There aren't many sort of formal studies, but Dr. Pimentel did a study in 2004 that showed that using Y1X, the trial of 93 SIBO patients, they had 66% symptom improvement after 2 or 3 weeks of elemental diet. And by elemental diet, I mean exclusive elemental diet. I mean, they're not allowed to take anything else other than water. They're allowed to have black coffee. So the response rate is actually for improvement and normalization of breath test was actually 80%, which is even better than antibiotics. Also, we know that elemental diet works on Crohn's disease, celiac, and even eosinophilic esophagitis or eosinophilic gastroenteritis. So if you have a patient that has overlap of those, this is an intriguing option. Another thing is that you should always tell your patients about chance of recurrence of disease to these patients, because so they understand, right? So they're not disappointed when the symptoms come back, right? I always tell them, you have about 50% chance of recurrence at 1 year. So they understand that it's not like a UTI that you just treat and it's gone. This is different. So diet. At Cedars, we use a low fermentation eating planning, which includes meal spacing plus a list of food that are not as restrictive as other diets, because of extremely restrictive diet eventually can lead to micronutrient and macronutrient deficiencies. So I use this as like a maintenance of remission modality. So what else do we use? We use migraine motor complex modulating drugs. For example, erythromycin at low dose we use. Also low dose 5-HT4 agonists such as prucalopride we use. There are other modalities obviously you can use. You can do those. Naltrexone has been used. Methadone has been used, but unfortunately, the number of pro-motility drugs out there are not a lot of them. So this is essentially how the algorithm that I've followed generally for bacterial overgrowth. So if I have hydrogen sulfide or hydrogen predominant bacterial overgrowth, I treat them with amoxicillin or ciprofloxacin. I mean, bismuth also works on them. And also, if you have excessive amount of methane, then I usually use rifaximin and neomycin for 14 days. And then I educate the patient about risk of recurrence and adopt a strategy for maintenance of remission, whether it's diet or it's a migrated motor complex modulating drug. And if symptoms recur, so obviously I repeat this. In the meanwhile, though, every time I do this, I always look at the underlying causes and whether there is something that I can change. So these are the take-home messages. So essentially, it has myriad of symptoms. We can diagnose bacterial overgrowth and also EMO with breath testing, and also breath testing. I showed you some data that helps tailoring antibiotic therapy and predicts response to rifaximin in IBS diarrhea patients. And don't forget the 3 pillars and revisiting them constantly when you're managing these patients. And this is our team. At this point, I'm happy to answer any questions.
Let's see. Let me ask the first question here. Dr. Rezaie, I know with your elemental diet, I was looking at the description of it in the book, and it's somewhat similar to a low FODMAP diet. Now, the low FODMAP diet has a certain amount of data to substantiate it. Why not go with a low FODMAP diet rather than the elemental diet?
Well, I mean, this would be a good question for a dietitian. They're not necessarily similar. The low fermentation diet is way more liberal. Low FODMAP is way more strict. So that would be that's essentially the difference. So the thing is that, yes, you're right. Low FODMAP diet there's a lot of data behind it. And because of that, we know that it's not healthy in the long run. And you have to reintroduce food within 1 month, which doesn't work in SIBO patients. Well, I mean, you reintroduce things in 1 month, well, symptoms are going to come back. So that's the issue.
Now, I know you're not a big fan of probiotics.
Mm-hmm.
Maybe you could tell us why.
Well, I mean, the bottom line is that SIBO is not a primary disease, right? So as we discussed, the main cause is this motility, right? So, and also a lot of other causes that leads to accumulation of bacteria, right? So pouring more bacteria in the small bowel is not going to fix that problem, right? And that's the issue, right? In fact, actually, patients with bacterial overgrowth can get worse with probiotics. I mean, there is a very interesting study that Henry Parkman did at Temple, that they give Bifidobacterium infantis to healthy controls. By the end of 1 month, the patients with the Bifidobacterium infantis started to have more bloating, distension, but more interestingly, they started to have more methane, which is fascinating. So we started to give them EMO, which is fascinating because Bifidobacterium infantis is a hydrogen-producing bacteria. So, and on top of it, the data with fecal transplantation with IBS is nothing short of disappointment at this point. And there are a couple of studies that are not just negative, they're showing that actually placebo is superior to FMT, meaning that patients are getting worse. So this, and if you think about it, fecal transplantation is the ultimate probiotics, right? And we know it works in certain situations, right? There is no question that they work in the setting of C. diff infection or the recurrence of it. But in this scenario, we're yet to see any robust data that it helps And if anything, we have data that it may be even making it worse.
Now, you mapped out the microbiome of the small intestine. So obviously there's benefits to having a certain amount of bacteria there. And one of the rationale for probiotics is we often use the analogy of a parking lot, and there's only so many parking spaces. And if you can park some good cars there, you can keep the bad cars from taking up those spaces. So if you're using antimicrobials or antibiotics and you're killing some of the bad bacteria, you might be leaving open parking spaces. And so that would be the rationale for potentially for using probiotics.
I mean, possibly that's, but clinical data is yet to pan out with that.
Right. Somebody asked if you could give that reference for the fact that colonic bacteria, it takes 40 minutes to produce hydrogen at a level that can be detected in the breath.
Sure. This study is done by Reed, R-E-A-D. That's the first author. It's in Gut and is published, I think, in 1985. So if you look at that study, they essentially infused lactulose in the cecum, and that led to rise in the hydrogen, and it took about 40 minutes for the rise to reach a level of 20 parts per million.
Let's see. Somebody mentioned that there's several studies that have shown, in fact, I'm pretty sure there's at least one meta-analysis showing that probiotics can be beneficial. And it's been hypothesized that probiotics actually have an antimicrobial effect. Let's see. Is SIBO really bacteria overgrowing from the large intestine, or is the bacteria coming down from above?
No, it's bacteria from the colon. So these are the disruptors that we see in the small bowel overgrowth that we see. And as we get closer to the colon, in SIBO patients, it's more similar to the colon. In healthy controls, it's not. So it's coming from the colon.
Is the importance of a healthy ileocecal valve important?
Yeah, IC valve is important. Yeah, and not surprisingly, not the patients with IC valve resection, they will have higher chances of bacterial overgrowth, but not all of them. But it shows that if you have healthy microbiome complexes, you're doing you will probably do well.
Given the fact that there are some patients who, as a result of Crohn's or some similar disease, have had to have their colon removed, they no longer have a normal colonic microbiome. And we know how important a microbiome is for health. In that situation, is it preferable for the small intestine to have a higher amount of bacteria?
Ask the question again.
Is there ever a scenario in which you might want the small intestine to have more bacteria? In the case of a patient who no longer has a colon because it was surgically removed, they no longer have a colonic microbiome. We know how important the microbiome is. In a situation like that, is it beneficial for the person's health to have higher bacteria? In other words, should their small intestine become their new microbiome?
No. So the way colonic mucosa interacts with the bacteria and the small bowel is completely different. So you can't really use small bowel as colon. So I can't think of a scenario. Yeah.
Okay. Great. Well, we really appreciate you showing up despite being sick with COVID, and hopefully you're going to recover quickly. If anybody doesn't have any other questions, then thank you very much, Dr. Rezaie. And
yeah, you're welcome. All right.
Thank you, everybody, for joining, and we'll see you next month. Thank you for making it all the way through this episode of the Rational Wellness Podcast. And if you enjoyed this podcast, please go to Apple Podcasts and give us a 5-star ratings and review. That way more people will be able to find this Rational Wellness Podcast when they're searching for health podcasts. And I wanted to let everybody know that I do now have a few openings for new nutritional consultations for patients at my Santa Monica Weitz Sports Chiropractic and Nutrition Clinic. So if you're interested, please call my office, 310-395-3111, and sign up for one of the few remaining slots for a comprehensive nutritional consultation with Dr. Ben Weitz. Thank you, and see you next week.